Bismillah ar-Rahman ar-Rahim. Mr. Chairman, I think Professor Kordi and Professor Amish said everything about, about the renal denervation. But I think there is a very important and very good review coming from the SKY position statement for the renal denervation 2023. Tell us everything about the renal denervation, even how to build a very good program. But as we know, for the competition or comparative between device and the therapy is very limited, and it's very hard to do that. But for the renal denervation, there is many resistant concern about the therapy effectiveness, the potential side effects. At the end, it is invasive nature and established traditional medical practice. So the willingness of the patient for this invasive procedure, how much can have amount of blood pressure drop and the suffering from hypertension and the complications. And to have at the local level, we must have effective collaboration. We need to define the problem, reveal the role of the renal denervation. We can show the effectiveness of the renal denervation, how to be done, because at the end, it is a very simple procedure from the interventional view. Also, the patient preferences, because can anybody in the room having or start hypertension, mild or moderate hypertension, need to do the procedure without taking any pills? Can the rich people do that if we have a safe procedure? I will not take pills from the start. If I have guarantee, I can have just one procedure and I will be for 5 years follow-up without any pills. Can any one of us accept the idea? Unfortunately, we have 3 patients in our hospital did this procedure without taking any pills. This is after the off-med trial. So we must discuss the side effects, the cost, the fear or lack of understanding the benefits, the high burden of the antihypertensive medication, and at the end, it is asymptomatic disease, especially if you have younger hypertensive patients. Of course, the dedicated hypertension center in the country, I don't know where in our country there is a dedicated solo hypertension center with multidisciplinary hypertension team, and the center including all the clinic and all the specialties. But how to get RDN team ready in particular, we must have hypertension specialists, interventionalists, nurses, anesthesiologists, and many other departments or other branches must be involved in the team. So the key criteria and approaches for developing RDN program: number 1, we must develop RDN multidisciplinary team. The second, build focus within the center and develop a referral network around the RDN center. If I ask Dr. Kordi and Dr. Ramesh, who is the main referral for you to do the procedure? From my point, the most important referral to you is your clinic. In Egypt, you must know your clinic is the first referral part to do this case. Because if you wait for other centers, for the local centers around the RDN center of your hospital to send patients, I think you will wait a lot of time. So for developed dedicated center for renal denervation, number 1, you must have personnel certified using the Medtronic or the Paradise system. Second, the process optimization, patient screening to assess the eligibility to renal denervation, and also, as Dr. Kordi said, the patient education, because the patient education is very, very important. Setting up a renal denervation team, multidisciplinary team, and access the international, national, scientific, and education opportunities. So I think this is the slide to summarize how can we build RDN program in a center or in a hospital? We need institutional requirements, key programmatic components, and recommendation for establishment as a referral center for RDN. The key programmatic components include primary physician stakeholder, an institution interested in performing RDN, and the multidisciplinary team, and of course, the support staff. The primary physician stakeholder at least have trained as a for the management of hypertension and the resources for screening, testing, and treating hypertension. The institution itself must be performing RDN will require a dedicated hypertension program or ensure appropriate expertise and the services of such a program designed to manage hypertension patients. The third part, the multidisciplinary team should be identified that shares in the management of potential RDN patients. This team should be identified as the chairs in the management of potential RDN patient. At the core of the team is hypertension navigator. And also the support staff, including the triage nurses, to follow up home or ambulatory blood pressures. We must have a pharmacy specialist and a nutritionist. All of those people must be in very good help and coordination with the team. So the first recommendation for the building of this program, the center should be experienced with using at least the currently available FDA-approved devices. We have two systems from Medtronic and the Record system. The operator should have participated in previous clinical trials or received appropriate minimum proctoring. The second recommendation, the center should incorporate the multidisciplinary team within their hypertension program to review the suitability and appropriateness of patient selection, determination of additional testing or medical therapy, and ultimately treating and managing patient referred for the procedure. The third recommendation, the center offers appropriate, reasonable access to the references procedure for patients within the medical center's network while maintaining quality outcomes. The fourth recommendation for establishment of a referral center for RDN should have the appropriate infrastructure, of course, necessary equipment, evaluating, treating, and management patient, include radiological services, CT, MRI, defining the renal and other vascular anatomy and the potential procedural complications, renal duplex ultrasound to directly image renal vessels and assess the renal blood flow velocities, general vascular ultrasound to assess potential access site complication. Of course, this is the systematic referral system from the primary care or the specialist treating hypertensive patients, diagnosing the secondary hypertension, diagnosing true resistant hypertension or true uncontrolled hypertension to refer those patients to a dedicated center for RDN. Dear colleague, we can conclude the appropriate patient selection, pre-procedure evaluation, careful procedure planning, and the technique implementation of strict operator training standards and the facility requirements are paramount to programmatic success. In my hospital, we started the renal denervation program since maybe 10 years, 11 years since the first simplicity catheter. Fortunately, our hospital, it belonged to a big authority. And the first issue in our hospital, there is complete reimbursement for the device. So there is no cost issue. The second, we have a very good heart hypertension clinic, including the cardiologist, the nephrologist, the endocrinologist, nutrition, and even cardiac rehabilitation physician. And for the start, we started for a patient with true resistant hypertension on 3, 4, 5 pills. As Dr. Cordy, we saw those patients along these years. There is very good, successful result stories I did by myself more than 115 cases with the Simplicity catheter, and with this type of the spiral Simplicity, we did in our hospital until now more than 50 cases in the last 1 year. So I think it is a very good technology. If we can help our patient to decrease the complication, I think, of the hypertension, I think this is very important, and thank you very much.